Hello, everybody. My name is Joseph Bay, and I'm representing the Pathcheck Foundation's team for the COVID-19 Symptom Data Challenge. Our approach is entitled Mining and Analysis for Symptoms in COVID-19, or MASC for short. I'd like to start with talking about our four primary contributions. First, we examine intriguing symptom correlations between various symptoms and features in the COVID-19 challenge dataset. We also demonstrate that less than 20% of these features can accurately model reported COVID-19 positive tests, and that self-reported symptoms can predict future COVID-19 positive test reports as well. Finally, we will demo our interactive and informative dashboard, which visualizes our results for our various experiments. So first, let's talk about our symptom correlation studies. Here we have visualized correlations for various symptoms reported in the symptom challenge dataset, as well as their correlation with the percentage of individuals reporting a positive COVID-19 test. On the right column, we have highlighted 4 different symptoms which have been clinically shown to be associated with COVID-19 infection. In blue, we have highlighted correlations between fever and anosmia with the percentage of individuals reporting a positive COVID-19 test. And in yellow, we have shown that those same correlations for cough and shortness of breath. It should be noted that our correlations highlighted in blue, so fever and anosmia, are positively correlated with positive COVID-19 testing, whereas our symptoms highlighted in yellow, cough and shortness of breath, display weaker positive correlations or no correlation at all with COVID-19 positive testing. This indicates that within our self-reported symptom dataset, certain symptoms might be more discriminative for COVID-19 infection than others, and this informs our prevalence prediction modeling and other approaches that we will discuss shortly. We've also performed correlation analysis between the rate of individuals reporting that they are avoiding contact all or most of the time in the symptom data challenge dataset, as well as their correlation with the rate of new confirmed cases from an external dataset. We stratified these studies across different population densities within different states. So for low density states, we have observed a negative correlation between these two variables. This is what we might expect. As individuals report that they are avoiding contact more of the time, we'd expect the rate of new confirmed cases to decrease due to self-isolation. However, in high population density states, we actually observe the opposite effect. There's a positive correlation between these two variables. This might form the basis for future studies into what other variables might be modulating the relationship between these two observations. We also, in these experiments, have introduced time lag approaches, where we've introduced a time lag in our analysis of these correlations. This can give us more insight into the temporal relationship between symptom manifestation and COVID-19 case rises in a population, and we found that by introducing a time lag, we were actually able to increase the correlations we observed between these two variables. Now, before we move on to our predictive modeling experiments, I'd like to talk a little bit about the evaluation metrics that we use to judge these models. In these slides, we will look at the mean absolute error reported for each of our models, or MAE for short. In our white paper submission, we also report statistics for mean relative error, or MRE. We believe that MAE is a bit more useful of a statistic in informing actions that are taken using model predictions, because they enable an individual or a government to plan for the margin of error that might exist from our models. Mean relative error might be useful in other contexts and provide other insights into model performance. So first, let's talk about our prevalence prediction experiments. Here, our goal is to predict the percentage of respondents that predict a COVID-19 positive test based upon other self-reported symptom data. Our methodology is briefly outlined in this slide and described in further detail in our white paper submission. Our results for prevalence prediction are detailed in this slide. In the table on the left, you will observe that we report low mean absolute errors using prevalence prediction models across a variety of different demographics and populations, including across male and females, as well as different age groups. In each case, our mean absolute error is on the order of 1%. It is also important to note here that the number of features required to make these predictions is actually far fewer than the total number of features contained in the COVID-19 Symptom Data Challenge dataset. By reducing the number of variables or features used for predictions from 35 or 36 to 10, we are able to retain model accuracy while also potentially providing the basis for creating streamlined, tailored surveys to individual populations and making our prevalence predictions. As you can see on the right, the ordering and inclusion of different symptoms actually varies between different populations, such as between males and females visualized here. This means that our symptom surveys that we develop can be made adaptive to a given individual's demographics. We believe that these results indicate the value in self-reported symptom data and potentially supplementing COVID-19 testing figures or other measures of prevalence. Let's now move on to our outbreak prediction experiment. And here we use time series approaches to predict future reports of COVID-19 positivity based on self-reported symptom data. Again, this is a brief overview of our methodology and approaches for these experiments. And again, you can read more in-depth descriptions of these details in our white paper submission. Our results for outbreak forecasting are quite promising. Our mean absolute errors are less than 1% across various states and demographics within these states. Here we've demonstrated just a few results for 4 different states. It should be noted that the models used to generate these results are tailored and individualized for each individual state, meaning we create a different model for each individual state in this case, or country in international data sets. We believe that the ability to predict future prevalence of individuals reporting a positive COVID-19 symptom test will enable individuals and governments to predict what the temporal evolution of COVID-19 infection might look like in the future. Now I'd like to briefly demonstrate our interactive dashboard. And what you see here on the screen is a visualization of our time series predictions across different states and demographics. At the moment, what you see on the screen is our model's predictions for COVID-like illness prevalence in California. We can adjust both the gender and age of population that we wish to predict in the upper right-hand and left-hand corner, and click on different states to review our model predictions in different geographic zones. For example, here we are looking at results from Texas. On our dashboard, we also visualize our results from our correlation studies, which you see on the right. And here we have an interactive, kind of nice visualization of correlation of various symptoms with COVID-19 positivity. On the left, we show a pie chart that shows the relative weighting of different symptoms used for prediction analysis that we saw on the previous page. Okay. There were several challenges that we faced in addressing the COVID-19 symptom data challenge. First, there was a concern that there might be bias in self-reported data, and that the self-reported symptom data might not reflect real relationships between symptoms and COVID-19. However, to address this challenge, we performed our correlation studies that we described earlier and queried healthcare experts to validate our features and models. Another challenge that we anticipated was the potential for regional variations in disease manifestations and self-reported symptoms. To address this challenge, we tailored our models and feature selection analysis to individual demographics and geographic locations. A brief summary of our approach here is that first, we performed correlation studies to both validate and question the understandings of symptoms and their relationship with COVID-19 infection. We demonstrated that for this self-reported symptom data set, certain known clinical manifestations of COVID-19, like cough and shortness of breath, were actually not very discriminative for COVID-19 infection. Furthermore, we showed that symptom data can be used to provide estimates of COVID-19 prevalence and be used to predict future outbreaks as measured by self-reported symptom data. We further showed that the number of features required to make these predictions varied between different populations, including by gender and by age, and that we could reduce the total number of features required to make these predictions from 35 to the top 10. This These insights might form the basis for the development of streamlined surveys that can increase user engagement and completion of surveys, just increasing and improving the quality of our data sets. We also demoed our interactive dashboard to visualize the results of our various experiments and hope to continue to build that out to provide more information and easily digestible information to the public. We addressed a couple of key challenges in this data challenge, and we identify various opportunities for future directions. The Pathcheck organization is currently involved in various pursuits in the setting of COVID-19, working on various projects across a variety of domains. If you would like to join us in our efforts and collaborate with us, please reach out on our website at pathcheck.org. Thank you for your time.